fracture is the gold standard really for articular cartilage lesions, and I think what we really don't understand is this definition of pincer impingement, and something like the real-time CT will really help us understand that, I think. Thank you very much indeed.
Great. Thank you very much, Marcus. That really gives you a very powerful insight into the kinds of things that I, as a radiologist, have to get my head around when I'm trying to report these studies. But equally, I get a huge amount of information coming to me from the other side of the problem, if you like, and the specialties allied to medicine who have a lot to do with these kinds of injuries, and particularly looking at physiotherapy and osteopathy and so forth, are absolutely vital to know what they're seeing, what their needs are, what their understandings are to these conditions. And it's a great pleasure now to introduce to you Nick Potter, who's an osteopath who I've worked with now for a number of years at the London Spine Clinic, and I think we kind of understand each other now, so. Just about. Anyway, Nick Potter, thank you.
Where do I just go? Hold on, so I've got nothing on the... Okay. Oh, is it sabotage me?
Yeah, I've sabotaged you.
You mackers.
There you go.
That's great, thanks. Well, thank you very much, first of all, for asking me to come and speak today. I think I'm afraid a slight deviation from what the advertised lecture I was going to give from disc problems, because actually having thought about it since we first talked about what I was going to speak about, I thought how incredibly dull, and if I had to sit there for half an hour, I think I would be bored simply about talking about disc lesions. What I thought I'd try and do is wrap up in one talk a little bit about what osteopaths do, because I know there's quite a mixed bag of people here today in the sense of GPs and maybe a few physios, osteos, chiros, I don't know exactly, but try and sum up exactly what I think we do. I'm very lucky to work in a truly multidisciplinary environment, so I can tap into the know-how and knowledge of a lot of my colleagues, particularly Simon, who has been invaluable to me, particularly in my research with necks, which is what I'm going to really speak about today. And I thought for the clinicians amongst you, it might actually be quite useful to go home with something that you might be able to use in your clinics every day, particularly diagnostically, which is a syndrome or phenomenon that I call the upper cervical syndrome. And it comes with a number of strange symptoms, but actually predominantly manifest in the neck as their cause. I've become strangely attached to this slide. This little girl is called Samita. I was actually reading the book on which this was the front cover. Rather strangely, it nicely slightly depicts what I'd like to talk about indirectly, the most phenomenal entity of the human body to use its balance systems, its musculoskeletal systems, simply to do this kind of thing. That is in fact her father's thumb that she's balancing on, and this was taken in Calcutta. Why I'm strangely attached to it is that in fact I looked inside the flyleaf of the book to see who had taken the photograph and see what it was of, and in fact very vaguely noted the name of the photographer and forgot all about it. Strange enough and quite spookily, the first new patient I saw on Monday morning was the photographer, and he very kindly, he was as spooked by the coincidence as I was, and very kindly gave me a copy of the photograph. So what are we going to talk about? A little bit of introduction. What does an osteopath do? But I promise not to bore you with that too much. But at how that links into this little phenomenon called the upper cervical syndrome, which is basically a combination of neck pain, disequilibrium, which is giddiness, waftiness, which very often I know from working with GPs makes them put their head in their hands because it's either something very serious or apparently nothing at all. And also cervicogenic headache, which commonly exists together and can very often mimic migraine, common migraine particularly. The causes and treatment, but then also a little bit about the role of the dynamic imaging. One of the things that we do as osteopaths is get serially fed up with being able to prove what we're actually feeling with our hands. And it's very nice to use this kind of technology to start doing that. And I'm sure many of the physiotherapists amongst us feel the same way. We have some of the most finely tuned images, if you like, in the form of our palpatory skills, but it's very difficult to prove it, but it's even more difficult to measure it. Why do most of our patients come into the clinic? Well, most of the time they're in pain, and this is a rather nice quote, I think, by a general from the War of Independence, and I think most of you would agree, but what it sums up is that pain is an experience rather than a sensation, and it is modified and modulated in the brain and everything else that goes with it, whether it's catastrophization or past experience, etc., all modifies pain, and more we're using drugs to change the way that we perceive pain and the different things that we can do. And obviously rehabilitation and therapy are very important in that. So what does an osteopath do? Good question. I could show you this, an incredibly dull and boring paragraph about what we think we do. I still don't think it's accurate. The only bit I would draw you to is the bottom thing. Treatment is often about, as I put it, unlearning old and abnormal patterns of physical behaviour, or engrams, within the tissues before re-educating them into a new and better one. So the concept of unlearning before you relearn. Sometimes rehabilitation in its own right is not enough. But moving on, this is what I think we do. What does that mean? I rather like this little quote, actually. I can't define it, but what I know what it is when I see it. That was by an American judge on pornography, but I thought it was rather nice. We treat function, in my view. If you take the orthopaedic surgeons, they're mainly the hardware specialists, and if you take the neurologists, they're the software specialists. I like to think that we're somewhere in between as technicians. We're trying to match up the subtle web that links all of those together, the actual way in which function really governs structure, and not the other way around. And I feel that in general terms in modern medicine we're increasingly becoming more reductionist, more subspecialist, and losing that subtle entity that binds it all together. It's amazing what some people will put their bodies through, and as I'm going to talk about next, I thought we'd have a few. This is a patient of mine who came to see me some years ago. I don't know if you can see it close enough. He is actually a co-pilot on board I think it was an aircraft carrier, obviously I'm not sure which one. He has in fact tried to eject during a panic when the first pilot was meant to eject first, and these are the sequential photographs taken as he comes back on board. You can see that unfortunately the ejector seat jammed. He did in fact deploy his parachute at the back, and he's now sitting halfway out of the aircraft at some 600 miles an hour. Miraculously he managed to land. You can see his arms out the back here. He fractured T2, 3 and 4, but also a little extension fracture his neck, but believe it or not managed to survive without any form of paraplegia, tetraplegia, and survived to tell the tale. Needless to say, I think he was mainly doing groundwork after that. This is another patient who took part in a ridiculous race at Goodwood called the Jalopy Race, sponsored, as you can see, by Lufthansa. And unfortunately, there are no brakes allowed in the event. And this is what happened as he came around the corner. There happened to be a sports photographer there, but he very kindly provided this as evidence of what he'd actually done to his neck. Amazingly, he got away without fracturing anything again. Obviously, American football, I worked in the States for a while. This is a rather nice image of what they call a helmet tackle. You can probably see that the mouth guard, which is still in his mouth there, is normally attached to the actual helmet. So you can imagine the hyperextension force. And interestingly, this phenomenon of letting go is not actually induced by pain, but is hyperextension and shock to the cervical cord actually causes this as a sort of letting go phenomenon. This one I particularly like. This was a gymnast I treated where, no need to say it, hypermobility was their issue. And lastly, this was probably the most miraculous of all, out in America in the Indy 500. And apart from 2 broken legs, he actually got away completely scot-free. I did a lot of my research in Formula One, particularly into necks, and was involved in inventing a thing called the hands device, which I don't think necessarily works very well, but it's designed to stabilise the head during crashes, but more predominantly during braking and cornering. And lastly, a catch that went wrong, but again you can see the impact and trauma to his head and neck. Again, miraculously, he was relatively unscathed. The trouble is that half of them, particularly if they're hard on the necks, like jockeys, etc., end up with this as a phenomenon, cervical spondylosis, with bony spurs, protuberances, cord compression, etc. But amazingly, all of these patients, this particular patient, despite these disc degenerations on scan and the beginnings of what looked like cord compression, actually has almost no symptoms at all after treatment, and the range of movement is almost completely normal. So I think we can depend too much on imaging and begin to treat the scan and not treat the patient. And all too often we can zoom in on things and not correlate it with our clinical assessment, which all too often is not really good enough. So the upper cervical syndrome, what is it? It's dysfunction in the occipito-atlantal axial complex, basically between C0, 1 to 2. There are secondary changes in the cervical muscles, predominantly due to pain induced by this dysfunction. The sternocleidomastoid and the suboccipitals and scalenes all actually shut down. And there's something else I want, a sort of confounding issue about the way neck x-rays are traditionally reported that I'd like to change the thinking on. And as a result, you get increased alpha neuron activity. These are proprioceptive and pain-sensitive active neurons, which feed into predominantly the trigeminocervical ganglion, which is a very large, long ganglion from the cranial nerve 5, which extends down actually as low as C2. So the body was designed to take in a lot of information through the cranial nerves from the neck as well. The causes, most classic causes, are the rear shunt in a car, the classic whiplash, and in fact the reason that I've postulated for why we see such a delayed onset sometimes in their symptoms is because in fact the neurological trauma, neuromuscular trauma to the suboccipital muscles underneath the occipital area doesn't take effect very often, sometimes days, months or weeks later, until they've got into a pattern of using their neck that they then get the pain. Very often they'll describe visual or even hearing deficits. Again, this is usually due to the complex neuroanatomy and the way that we use our upper cervicals to tell us where we are in space. So again, going back to the balance analogy, this really is the link in between the way the upper cervicals work and that we use our visual fields and our vestibular mechanisms to actually balance. Hence, the giddiness becomes a problem. Very often when I first started treating this, I couldn't believe that patients were saying, well, it's amazing, I feel better, but also I seem to be seeing clearer. And initially I couldn't understand this, but it is in fact true. And in fact, we now know that it's from improvement in their accommodation reflex. Their pupillary dilatation actually improves because they can begin to target better using their vestibular mechanisms more efficiently. The hearing deficit is also related. We use a lot of our hearing as well as our vestibular mechanism to actually sight objects. So again, when we retrain these people, we very often put ear muffs over them so we can focus on particular parts of their retraining. The non-traumatic ones are tummy sleepers, people who sleep on their fronts, and the worriers, the type A's who clench their teeth at night. Very often, both of those are also secondary to a more traumatic response, so they're codependent. Very often, any unilateral occupations, people who sit in cashier desks going from right to left, looking across at screens that aren't central. Laptops are my big hate, and we're all beginning to use them more and more, but in fact, what we do, unlike a desktop, is shear the neck. Flexion doesn't matter, it's the shear that's the problem. That advances degeneration in discs and the upper cervical problems much quicker than flexion. You can look down for ages with no problems, but you cannot shear. If on top of that you're slightly short-sighted or have a visual field defect, then you'll begin to squint very quickly. The shear mechanism comes on. Chronic poor posture, the forward head posture, which again is related to desktops, etc., and I will talk a little bit about that later. And very often people with sleep apnea, they're mouth breathers. Because they're mouth breathers, they hyperextend their necks at night to try and get air, and this contributes to obviously also snoring. Anxiety and hyperventilation is another thing that I'm very interested in because I think a lot of it actually contributes massively to this, but equally this causes the other. Hyperventilation, I reckon, is probably in 60% of the population. We all lead very stressful lives, and as a result, we begin to shallow breathe. If you shallow breathe, you shut down your diaphragm. If you shut down your diaphragm, you use your accessory muscles. They are not designed to be used all the time, and they shorten and they encourage forward head posture. Irritation to the suboccipital area makes them become teeth clenchers. It switches on the muscles of the face, and the whole thing becomes a vicious circle. So very often the reason you'll see the people who are the type A anxious people who've got the headaches is because they're locked into this little vicious circle. This is just a thing I actually normally give as a handout, but it's a very interesting evidence-based document which is all the side effects of hyperventilation, and very often those patients who endlessly go around neurologists with strange pins and needles, tingling, etc., this is never considered. I've almost never seen it diagnosed in a patient, and yet so many of my patients come in and the first thing they need to do is to learn to breathe properly. Classically, they produce this foggy brain, dizziness, lightheadedness, and in ladies, when they're in their menstrual cycle, the increased progesterone actually increases the effects of all of this, which is also quite interesting. Anyway, moving on. I won't bore you with this. This is all obviously the actual physiological aspects of hyperventilation. I've put them really in for the handouts more than anything else. The symptoms of the upper cervical syndrome are headache, which are very often quite long duration, and it very often mimics migraine. It will come with dizziness, and it can often make them feel sick, where they probably usually aren't actually sick. Usually they will get a hemicrania, a facial pain, which is usually one-sided, and it's very often occipitofrontal, again mimicking a migraine. They will often even say that exertion, coughing, sneezing, valsalva will also aggravate it. They very often will get TMJ pain, which can actually mimic what they call otalgia, so they tend to get an earache, which again often gets referred to ENT